So we are starting the next session. First speaker for this session on lower limbs is Dr. Sanjay Bhanankar. And Dr. Bhanankar was a contemporary of mine in Goa Medical College. We did our anesthetics together. He is now, he did his training also in UK, finished his training but didn't take any consultant job in UK and decided to go to US. And he's a professor of anesthesiology and pain medicine in Seattle, University of Washington. He is also chief of regional anesthesia and pediatrics. And if you Google his name, you will see lots of good articles on regional anesthesia. So Sanjay, the podium is yours.
For blocks to be successful, it's very important that we need to know exactly what we are looking for, where we are expecting to find it, and then only you'll find it. It's important to know the pharmacology, short-acting, long-acting, very long-acting, what we are going to use, what's the maximum dose, how are we going to manage it. It's one of the things my residents and trainees do is once they start using ultrasound, they forget about all other things that we can use. And I say, no, we have got so many other ways to locate the nerve. We've got the landmark. We did, Prashant and I, we did nerve blocks just using landmarks. There was nothing else. Paresthesia is when the patient tells you, yes, I'm feeling that electric shock-like sensation going to my little finger. Yes, use that to locate nerves. Use stimulation if you have got. Use ultrasound. Because you never know where you will be. There may be some day when your ultrasound machine fails, and if that's the only way you have learned to do, you won't be able to do any blocks. Practice, practice, and practice more, especially with ultrasound. Just, if your patient is asleep, you've got an ultrasound machine right by your side, and it's a boring 3-hour case. Why not scan the neck? Why not scan the armpit? Why not just look at the anatomy? We don't really need a patient consent to do this kind of things under anesthesia. Some people say, oh, the block didn't work. It looked so good on ultrasound. I went into the corner pocket. I dissected the whole thing. Oh, my God, and the block is not working. Why? Probably they didn't wait long enough, especially when we're talking of sciatic nerve block. Yes, the onset time is really long. It can be 40 minutes. And I have seen that in about 45 minutes set up despite using high concentration local anesthetic. And whenever you are doing a block for surgical anesthesia, always have a plan B and C. What if the block doesn't work? I know the anatomy was perfect, you put enough volume, the spread was good, it was long enough, still plan B and C. So if there is somebody you are likely to be unable to intubate, you can't say, oh, I'm going to do this case under regional, and then the regional block fails, and then you don't have a plan B and C, it's not going to work out. So when dealing with lower extremities, Dr. Pandey and I, we are splitting this session. He's going to talk about almost all the blocks, and I'm going to talk about a block and a half. So the one block I'm going to talk about is the sciatic nerve block. So that's how sciatic nerve is formed all the way from L4-5 to S3. And people have described so many approaches to blocking this nerve. There are more. I've just listed the common ones that I have used at least once. So what happens is, as the sciatic nerve is coming out, and I need to shine the pointer, not in my eye, I guess. Okay, as the sciatic nerve is coming out, there is a parasacral approach described, again using landmarks. Posterior superior iliac spine to ischial tuberosity, 6 centimeters below. If you go with a stimulator, you should find the sciatic nerve. This is the classic Labat approach that is described, where you have to trochanter, you draw lines, drop a perpendicular, and right there where the perpendicular meets the two lines, again with stimulator you should find the sciatic nerve. Can you do these blocks with ultrasound? Not me, but maybe some of you can do them because they're pretty kind of challenging to locate the nerves in those locations. When we come a little bit lower down, when we come to the subgluteal region, it's possible to do that. So if you have a nice low frequency it in this point right between the greater trochanter and ischial tuberosity, and you can feel them even in obese patients with a little bit of things. You can feel them. So if you put the probe there right in the center of your screen, you should find the sciatic nerve. And some people go with the probe in that direction. Some people try to locate the nerve that way, but it's possible to trace it. And in these cases, though I'm almost confident that what I see on the screen, that hyperechoic thing is the sciatic nerve, I encourage my trainees and my colleagues, just use nerve stimulator, because all the needles that we do blocks with, they always have the little extension for nerve stimulator. We don't even have needles that don't have the electrical extension. So if you have it, what is the harm in using it? It is not below my ego to say, oh, I'm going to take additional help. It's a way of ensuring more success. There is anterior approach described as well, and there are two anterior approaches described. We won't even go there. Using ultrasound, I have done this, but again, I don't do them only using ultrasound. I want to be a little bit better. So the block that I'm going to talk about is the popliteal approach to sciatic nerve. And that's what a cross section should look like. You have your groove, like how Dr. Kakodkar was saying, the groove between biceps and triceps in the upper extremity. Here we are looking at the distal thigh, the groove between vastus lateralis and biceps femoris. And if you come there, you are right at the posterior sciatic nerve, where the two components are together. Now remember, when you're these needles, the needles that we do blocks with, they are blunt needles. Their their bevel is so blunt that when you poke the nerve with the needle, all that you do is you displace the nerve. It's not easy to get into the paraneural sheath. Lot of difference. So what is described as an intraneural injection versus extraneural? So intraneural, when we say, it's another separate topic. It's probably worth hours of discussion. But there are so many layers to the fascicles. So we have a paraneural sheath, which is trying to poke and get into the paraneural sheath. And one of the things that he did here, which is worth noticing, is as his, so he's got his needle in there, he's poking at the nerve, and at some point I tell him, just let go of the needle and see what happens, which is probably the sliding thing that Dr. Gaur was talking about. And you'll see that the needle does not stay in position. It just, he doesn't, look at that. So when he let go of the needle, he took his hand off the needle just dropped down. So the needle is not kind of anchored. It's not in the paraneural sheath. So if you inject there, the block is going to be very patchy, if at all. If you get a block, you're lucky. So I'm trying to tell him to go into the paraneural sheath, and maybe, so here I think he is inside the paraneural sheath. So I'm asking him to aspirate, inject, so that first little white blob that you see here, this is like a 0.1 ml of air that was injected. Air is very hyperechoic, so you get that air injection. And now he's carefully aspirating and injecting 3 mLs at a time. So that goes on. That goes on, and what is this one? And now you can see the spread of local anesthetic. So this is a after we have done everything, we have put in a catheter. So this is the catheter that you can see. And whenever I put in a catheter, my preference is to inject through the catheter rather than inject through the needle, because I want the catheter to work. I want the patient to have 48 hours of analgesia, and I don't want my needle injection work. You can see how well you can. So I don't want that the original block with the needle worked fantastic for 8 hours. I have no idea where the catheter is. Now the block has failed. That's failing my patient. So I always say inject through the catheter. Show me where the catheter is. And I think in this video you will see that so these are the two divisions. We have split up the sciatic nerve into the peroneal and tibial component. And the first injection is occurring a little too far. It's occurring here. So I'm telling him, pull back the catheter, and you will see him there. Look at that. So the catheter is coming back, and that's the tip of the catheter. And he's aspirated, that's what we saw, and now you can see the volume of injected. It's spreading anterior to the tibial component, and as it keeps on injecting, it's spreading posterior to the tibial component, and it's kind of in the paraneural sheath. It's separating the two nerves nicely. So that's about sciatic nerve block. The other thing I'm tasked with describing today is a lumbar plexus block. Now, lumbar plexus block should not be considered for novices or intermediate. You really should practice this block under somebody who has done this block hundreds or thousands of times before you venture into it. The best way of finding out where you should put your ultrasound or needle or whatever is this little thing. You've got to have the patient lateral, draw a line on the highest point of the iliac crest, draw the midline along spinous processes, draw a parallel line along posterior superior iliac spine, split this line into 3, a centimeter above that should be where your L4 transverse process is. So that's the best way of locating the L4 transverse process. And this slide is there to just remind us of what all things are there right next to this lumbar plexus. First of all, the lumbar plexus, even in thinnest patients, could be 6, 8 centimeters deep. In obese patients, it's like 10, 12 centimeters deep. So when you're poking blindly into something that far, my heart skips a beat sometimes. IVC, aorta, kidneys, colon, lots of things around that you won't even recognize that you have gone into. And unless you are a proficient ultrasound person, it's not easy to find the lumbar plexus. When you look at textbooks, they keep showing you this beautiful picture. Look at that. And then when you have this, which is labeled transverse process of L2, L3, L4, lumbar plexus, and that's psoas major muscle. So easy to do this block. Try getting this view, and I bet that you'll have to scan about 50 patients before you get any view that's kind of close to this. So don't think that you can do it, but a lot of my colleagues think that lumbar plexus block is a little overrated, and they say, well, if this patient really needs analgesia, there are other methods of providing analgesia. I'm not comfortable doing it because I don't do hundreds of those every day. I will speak just a couple minutes about not real advances, but things that we are doing in Seattle. So any of our regional anesthesia doctors, nobody is comfortable doing any block without an ultrasound. So ultrasound has become complete standard of care. It's not even routine. We have a point of care ultrasound technology, and I was showing some people where Philips has manufactured a probe, something that we want to do. Some people want to scan the lung, check if they have a pneumothorax. Some people even scan the heart with it. So if you need, it's always available. So very portable. It sits in a little bag. It sits in where the anesthesia group sits. Continuous catheter patients and outpatients. So there are quite a number of patients who have bony surgeries on their foot and ankle, and we are comfortable sending them home with a catheter in place connected to a portable disposable pump. We know that ultrasound use really reduces one complication, that is accidental intravascular injection of local anesthetic. Other complications like nerve damage, probably not, but one complication that it reduces is accidental intravascular injection. So I was talking about disposable take-home pumps for patients. So this, I have no allegiance to this company, but it's made by OnQ. It's an elastomeric pump that can be filled with up to 550 mLs of any local anesthetic that you want. The most commonly one we use is 0.25% bupivacaine, 0.25% bupivacaine. And it has just a little flow controller that you can set the rate between 2 and 14 mLs an hour, and you send the patient home and tell the patient when you're ready, when your pain is better, just take out the dressing, pull it out, and make sure that the catheter tip is intact. Send me a picture of the catheter tip to make sure that you pulled out the entire catheter and a fragment is not sitting next to your nerves. There are other companies. This one is called Ambit. You can have a big bag of local anesthetic if you like. You can have a liter bag of local anesthetic connected to this. It even has a patient-controlled analgesia button. So you set a baseline rate, so say 6 mLs an hour, and if the patient wants to give himself a bolus, pain is not really under control, he can give himself a bolus. But the same thing, at the end, when you're done with it, you can just pull out the catheter and throw it out. Liposomal bupivacaine is being used increasingly not by anesthesiologists but by our surgical colleagues. So that way the number of blocks that anesthesiologists do may be going down, because things like we used to do tap blocks or we used to do paravertebral blocks. Now they prefer to infiltrate liposomal bupivacaine themselves. And it's got a good reasonable action till 72 hours. There are problems with its use, and anybody interested, we can talk about that later. But right now, at least in the US, it's not approved for nerve blocks. It's only approved for tap blocks and for infiltration analgesia. And the final thing I just want to say that whenever we do peripheral blocks, sometimes we get inadequate analgesia, so always have that plan B. If the patient does not get satisfactory pain relief, what are you going to do? What adjuncts are you going to use? Other problem we see sometimes is, as long as the peripheral nerve catheter is working well, the patient is very happy. You take the PNC off and he's like, oh my God, this is excruciating. You need to do something. I can't take it any longer. What do? Do you replace the block? Do you switch to alternate modes of analgesia? What do you do? There is a question of motor block, and I'm sure Dr. Pandey will talk about motor block with saphenous nerve block or adductor canal block, and can be associated with falls as the patient try to ambulate. So our aim is to provide a good sensory block without motor block, and I guess we are looking for the ideal anesthetic to get that. And that's all I have to say, and if you have any questions, I'll be happy to answer now, during lunchtime, end of the day, but unfortunately I'm flying back tomorrow, so I'm here only today. Thank you.
We'll take questions at the end of the 2 lectures, I think. We'll call Dr. Pandey now to talk about his part. Dr. Ravindra Kumar Pandey is a professor at All India Institute of Medical Sciences. His interest, in addition to regional anesthesia, is in renal transplants and intensive care medicine, and he has published widely about 280 indexed papers. So let's hear Dr. Pandey, and then both of them can demonstrate to us some of the blocks and take questions while the demonstration is being done.
Sanjay.
I'm not going to describe the details anatomy, but I'll deliver the basic lecture, like it will help you in your day-to-day routine practice. So the topic I will cover is a lower limb block. Before that, I want to give some advantages of ultrasound, that you can see there's a direct placement and direction of the needle, and you can see the spread of the local anesthetic, and it is safe because there's a reduced risk of vessel puncture and injury to vital structure, and it is also helpful in obese patient where the palpation of artery is difficult. So today I will cover these topics: femoral nerve block, obturator nerve block, adductor canal block, and fascial lacca block. I will not cover the ankle block because it further needs a spatial, like a separate session. So because of the lack of the time, I'll cover only these 4 blocks. Coming to the anatomy of the femoral block, femoral nerve, it is a mixed nerve, it is the largest branch of the lumbar plexus, and it runs in the pelvis behind the inguinal ligament, and it splits into anterior and the posterior division. So in femoral triangle, it is lateral to the femoral artery, and this is important. And its terminal branch is the saphenous nerve, which is purely sensory. So this is the cross section where you can see the middlemost part is the vein and then artery and the nerve. Here it is clarified, and this is the sonoanatomy. You can see the hypoechoic hollow structure is the femoral artery, and this flat, you can say triangular oval shaped structure, hyperechoic, is the femoral nerve. The indications, as you know, that femoral nerve supplies the anterior and the medial thigh down to the knee, and variable strips on the skin on the medial side of the leg and the foot, and it also supplies the articular branches to both hip and the knee joint. Coming to the essential of the femoral nerve block, so it is for the students that you need for any block you need the 2-3 things, that is patient position, you know the anatomy, you know what type of probe, ultrasound machine you have to select, what type of probe, and what is your goal, and what is the quantity of the local anesthetic you are supposed to use. So in femoral nerve block, basically the in-plane technique and out-of-plane technique, they have been described. In in-plane technique, the patient should be supine. I'll demonstrate on the workstation as well as on the master block when I will show. And here the palpation of femoral artery is not required, and the probe is placed transversely on the inguinal crease, parallel to the inguinal crease. And if you want to use the nerve stimulator also, then you have to expose the thigh as well as patella to show the patellar twitch. Femoral nerve for depth, here you have to set a depth of 2 to 4 centimeter for femoral nerve block, and as I have told already that it is a hyperechoic and triangular or oval shaped structure which lies lateral to the artery, and it is covered by the fascia iliaca. However, the femoral vein and the femoral artery, they are enveloped by the separate fascial sheaths. So your goal is to keep the needle tip either below the fascia iliaca or below the nerve or in a wedge-shaped tissue space lateral to the artery. I'll show this thing on my master block session. And out of plane technique, the needle tip may not be visible throughout the procedure. This is the drawback of all out of plane technique. So for that, to locate the tip of the needle, you just inject the small saline boluses of 0.5 to 1 mils while advancing the needle towards the nerve under ultrasound guidance. For continuous femoral nerve block, the catheter is placed in the vicinity of the femoral nerve, and the two factors are predisposing to the catheter dislodgement in this block. One is the inguinal area, which is quite mobile, and femoral nerve which is not quite deep. So the starting point of the needle should be as lateral as possible, and through muscles, because muscles stabilize the catheter. So there are less chances of the dislodgement of the catheter. Coming to the erector canal block, first of all, anatomy, that is, it is a aponeurotic canal, and which occupies in the middle 1/3 of the medial most compartment of the thigh. And the extent of the adductor canal is, it starts from the apex of the femoral triangle above to the tendinous opening in the adductor magnus muscle. So the roof of the adductor canal is formed by the sartorius muscle. Laterally it is bounded by the vastus medialis, and posterior-medially it is bounded by the adductor longus and adductor magnus muscle. So this is the adductor canal. The superior, roof is formed by the sartorius, which is a board-shaped muscle, and this is the landmark of this block. You have to identify this board-shaped muscle, that is a sartorius muscle. Laterally it is bounded by the vastus medialis, and posterior-medially it is bounded by the adductor longus and adductor magnus. Contents of the adductor canal, in spite of along with the saphenous nerve, you will get femoral artery, femoral vein, posterior division of the obturator nerve, and nerve to vastus medialis muscle, and other nerves also, medial femoral cutaneous nerve, and branches of anterior and posterior division of femoral nerve. This adductor canal block is very much similar to the axillary block. Here there is no separation of the artery, vein and the nerve. So you should be very careful because you are totally concentrating on the artery, and you most of the time you press the vein with the pressure of the transducer. So there is no compartmental, there is all nerve, vein and artery, they are in the same compartment. So you should be very careful, like in axillary block. So David Bond et al. He published first this article in Regional Anesthesia and Pain, and he said that adductor canal block is not only the, it's a wide extensive block, because he has observed that in spite of saphenous nerve, the so many other areas has been blocked. So I has already shown you that obturator nerve also passes through it, and medial cutaneous nerve of this femoral nerve is also passes through it. Coming to the relations in the adductor canal, when you see the adductor canal, the upper part of the adductor canal, the femoral artery is lateral, the saphenous nerve is lateral most, and femoral vein is the medial most. In the middle part, the femoral artery is anterior, femoral vein is posterior, and saphenous nerve lies lateral to it. When you give this block in the lower part of the adductor canal, you will see that femoral artery is the medial, saphenous nerve is the medial to it, that is medial most structure, and femoral vein is lateral. Coming to the indications, according to the surgical indication, it is divided into high volume block and the low volume block. So for the procedures like ACL repair, meniscal repair, and in combination with sciatic nerve block, you can use the volume of 5 to 10 mils. However, for total knee replacement, you have to use the volume of 20 to 30 mils. Contraindication, there is no specific contraindication. You should be very careful, and there is no specific complication in this block. Then in plane technique, you ask the patient to lie supine, abduct his leg, and it should be flexed at knee joint and externally rotated, so that your medial most compartment is exposed. And then you have to adjust, take a linear probe and adjust the depth of 4 to 6 centimeter, and the landmark is that femoral artery is under the sartorius muscle. Goal is to, as saphenous nerve is too small to be imaged, so aim is to place the needle tip lateral to the femoral artery below the sartorius muscle and deposit 20 to 30 mils of local anesthetic until it is spread around the femoral artery. The out of plane technique is also acceptable. I usually, when there is a long needle is available in another department, I use in plane. When there is a short needle, sometimes it is not available, only 5 centimeter needle is available, then you can use out of plane approach also. Now, when there is a difficulty in identifying this femoral artery, first check the depth, whether the depth is adequate or not, because don't get panicked, see the depth, whether you have adjusted the proper depth or not. Then move the probe circumferentially, use the color Doppler, and if still the difficulty persists, then follow the femoral artery from distally. Extreme caution is taken, because I have already told you this is a compartment where the artery, nerve and veins are not separated. Coming to the obturator nerve block. This obturator nerve again arises from the ventral rami of L234. It travels along under the psoas muscle and emerges out through obturator foramen. And it divides into anterior and the posterior division. Anterior division passes in front of the adductor brevis muscle, and posterior division behind it. Indications are, as this is purely this is a pure sensory block, and so the sensory supply is medial side of the thigh, and it also supplies the hip joint anterior division and knee joint posterior division. Other indication of obturator nerve are prevent adduction of the thigh during the transurethral bladder, because most of the time your patient is too much moribund that he only the regional block is not a fit patient for general anesthesia. So you plan regional anesthesia, that is a spinal block along with the this obturator nerve block, because sometimes the bladder in lateral the tumor present in the lateral wall of the bladder, this obturator nerve, you know, it runs close to the extremity, and when it got stimulated, there is a rupture of the bladder wall. So you have to along with the spinal, you have to block the obturator nerve. The non-surgical indications are spastic adductor syndromes and relief of painful adductor muscle spasm. How to perform this block? Again, the selection of transducer and position of the patient. You need to select 6 to 13 megahertz of linear probe, set a depth of 4 to 6 centimeter, then patient position is supine and leg is abducted and externally rotated. Goal is to inject the local anesthetic in interfacial plane, muscle plane where the nerve division lies. And the quantity used is 5 to 10 mils for each division. How to perform this technique? You see that like a femoral, you have to locate the femoral vessel, keep the probe on medial aspect of the thigh, distal to the inguinal crease, and then slide it medially over the adductor compartment. You can identify a Y-shaped facial convergence. This is Y-shaped facial convergence. So this is the this is the pectineus muscle. This is adductor brevis, this is adductor longus, and this is adductor magnus. So anterior division lies between adductor longus and brevis. This is hyperechoic structure, and the posterior division lies between adductor brevis and the adductor magnus. So this is the because you have to concentrate on this Y-shaped facial convergence. This obturator muscle is the flattest muscle of the body. So it is basically interfacial plane block. How to assess the effectiveness of the block? Since it is a sensory, this innervation of obturator nerve is highly variable, so have to rely on the motor component. So obturator nerve is assessed by evaluating the adductor muscle strength. So simple method is to adduct the blocked leg of the patient from abducted position against the resistance, and if the patient feel weakness or inability to adduct the leg, so you can see that, you can say that the block is successful. Again, the two techniques are described: in plane technique and out of plane technique. Facial iliaca compartment block. It is alternative to femoral nerve block and lumbar plexus block. In intra-pelvic region, the femoral nerve, the lateral cutaneous femoral nerve, they lie under the fascia iliaca. So the fascia iliaca compartment block is a large volume block. It is you use 30 to 40 mils of local anesthetic, and the block results are there is a 100% blockage of the femoral nerve, 80% blockage of lateral cutaneous femoral nerve, and anterior branch of the obturator nerve is unreliable. Indications are anterior thigh and the knee surgery, and it is a block which is good for analgesia for hip and knee procedures. Again, selection of probe is again 5 to 13 megahertz, and you need 2 syringes, standard nerve block tray, and 8 to 10 centimeter of needle, and sterile gloves. The local anesthetic used is as 30 to 40 mils. Technique: the patient should lie supine, skin is disinfected, transducer is moved laterally until you have to again you have to localize the femoral nerve, and then fascia iliaca above it, and then you move the transducer medially and laterally until the sartorius muscle is identified, and after making the skin wheel, this needle is just inserted in plane to pass through the fascia iliaca. After negative aspiration of 1 to 2 ml of local anesthetic is injected to confirm the proper position of the needle tip between the fascia iliaca and iliopsoas muscle. A proper injection will result in separation of fascia iliaca by local anesthetic. Goal of this block is to place the needle tip under the fascia iliaca approximately at lateral 1/3 of the line, connecting the anterior superior iliac spine and pubic tubercle. And success of the block is documented by a spread of local anesthetic towards femoral nerve medially and below the sartorius muscle laterally, below the fascia iliaca. And in obese patient, out of plane technique is favored. So this is how you can see that the local anesthetic, which is below the fascia iliaca.
So that's good. Can you put a little color flow and show me the popliteal artery and the vein? Thank you. So you should be able to see, before even trying to identify any nerve, I just want to identify where the popliteal artery and the vein is. Now what has happened is, because his leg is high up, the venous drainage is very prompt. So it's difficult to kind of look at the vein. It's there right on top of the artery. So it's superficial to the artery. But what I can do here is I can squeeze his calf muscles, and every time I squeeze his calf muscle, you'll see a little kind of gush of blood coming into the vein. So I had a pointer. So anyway, the vein is there, and the vein is there, which I can kind of release the pressure and show you. But the moment I put pressure, the vein disappears, right? So now, is there a pointer? Somebody has got a pointer? Or maybe Prashant, you can point out the tibial nerve right there coming into screen. Let's take off the color from there, please. So, so I see the tibial nerve. I'm looking for peroneal nerve, but I'm not in a rush, right? So what I'm doing now is it's dynamic scanning, as Dr. Gaur was telling us. So I'm sliding the probe cranially. I'm going up in the thigh, and I do see the second kind of peroneal division. So that's the common peroneal nerve that came together, and it joined the tibial nerve, and there we have a common kind of sciatic nerve in one paraneural sheath, right? So our volunteer is really slim and trim, and I think that this depth is 2.7 centimeters here. So this is like just under the skin. Where did I lose it? This is literally just under the skin. There are not too many muscles to see. So my next thing is, just because I found the nerve, I'm not happy. I want to confirm that it is the nerve. So you see the nice fascicular structure. Can you reduce the depth again, please? Okay, so the least depth that you can get. That's it, okay. So I want to go again and go down again, and I want to see those nerves separate and go in two different directions. And now I'm going up cranially into the thigh again, and I want to see them come together and go down again. And when I say practice, 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 that's what I mean. You just need to be able to kind of scan and look at the nerves coming together. It's not about, if somebody takes this probe, just puts it here and tells you that's the sciatic nerve, I don't believe him. I don't believe it at all. So I always want that dynamic scanning. I want to be able to see the nerves coming together and whatever. Any questions about the technique or about the approach?
So for this femoral nerve block, we have to make the position supine. You need a linear probe of 5 to 12 or 6 to 13 megahertz frequency. And you just keep the longitudinal, this long axis of this probe parallel with the inguinal crease. Okay? Yeah. So your main aim is to, yeah. So you can see there are two pulsatile structures. Okay? And both are artery. So this position is wrong. One is femoral artery and second is branch. It means you are more lower. So you have to move your probe up and make this structure single. Okay? Now this is the right place. You can see a lateral to the artery. I mean this side is lateral. This side is lateral, this side is medial. You can see one artery, hypoechoic structure, which is pulsating. You can put Doppler also for confirming it. And this is a muscle, which is iliopsoas muscle. And in the sulcus of iliopsoas muscle, you can see femoral nerve, which lies. This is the femoral nerve. Don't confuse with the wedge-shaped space. In this patient, it is clear-cut. You can see this is a femoral nerve, which is a flat, oval or triangular shaped muscle, lies in the sulcus of the iliopsoas muscle. Now with the same position, you just move your transducer medially towards the adductor compartment. This black structure is a pectineus muscle. Okay? Further movement, you can see, इसको depth थोड़ा सा बढ़ा दो. Just for this obturator nerve block, you have to adjust a depth of 4 to 6 centimeter. So further moving your probe medially, you can see this is pectineus, and then you can see 3 muscles. The above one is adductor longus, middle one is brevis, and lower one is, magnus. So the upper hyperechoic structure is the anterior division of the obturator nerve, and the lower hyperechoic structure is the posterior division. So when you need analgesia for knee surgery, you can be more specific. You can only block the lower, this is posterior division. And for the hip, sorry? Yeah, this is the posterior division. This is the anterior division. These are the 3 nerves: adductor longus, adductor brevis, adductor magnus. This is the anterior division. This is the posterior division. Okay. So you have to inject the local anesthetic in this facial sheath. So after this, when you before that, you have to give some saline, that is known as hydrodissection. So it will start separating here, and then you inject. Then sometimes the obturator nerve is visualized.
Okay, I think you nicely demonstrated the nerves, femoral, rest of the things we
I think
going to hand.
Adductor is this is adductor, okay? It is, I have just in the middle part of the medial side of the thigh, I had directly put this, my probe, and you can see a board-shaped structure. Yeah, board-shaped structure. It is a sartorius, okay? And the lateral one is the, you can see the artery, which is, now I am releasing the pressure. You can see the vein is also appearing below the artery. So I have kept in the middle part of the adductor canal, where the vein lies posterior to the artery. Okay? When you keep the probe above part of the adductor canal, vein lies medial to the artery. So here you can see that the board-shaped structure is a sartorius muscle. The laterally it is a vastus medialis, and the medial boundary is formed by the adductor longus and the brevis. Rest of the thing I will explain on the workstation.
Yeah.
Okay?
His interests are also regional and peds, like Dr. Banankar, and he has done about 25 publications, written about 6 chapters in books. So he's going to talk to us about the truncal blocks, and we are not going to have a demonstration after this. Again, the demonstration will be with hands-on.
So what exactly these blocks, the definitions. The PEC one, first you described the deposition of local anesthetics between pectoralis major and minor. Then PEC 2 is the PEC 1 plus another injection between pectoralis minor and serratus anterior at third rib, and sometimes under also fourth rib, and serratus plane block is which is also called PEC 3. So injection of local anesthetic again below the serratus anterior muscle at the level of 4th or 5th rib. So I will say again, it's either below or above. It's inside or outside. So why are these blocks? We were using actually paravertebral block. Why are these blocks? So the reason is, of course, paravertebral block can cause pneumothorax. Not that these blocks don't cause, but again, the incidence is higher on that side, number one. Number two, the innervation of the anterior and lateral thoracic valve is not just from the spinal nerves from the thoracic spines. We also get nerves from brachial plexus. So these blocks will help us not just blocking the thoracic nerves, they also help us to block some nerves which are coming from brachial plexus. Unlike tab blocks, they are becoming very, very popular among all the anesthesiology providers. So brief anatomy, as you know, there are 4 nerves come from which innervate the anterior and lateral wall of the thorax, which is the next slide I can show you. So if you see that all the yellow ones, which is lateral pectoral, medial pectoral, then thoracodorsal, long thoracic nerves. So these are the nerves which supply the anterior and lateral wall of the thoracic. That's why we are interested in that. So here, the brief anatomy, So this is medial lateral pectoral nerve. This is medial pectoral. There is a connection between them. It's vasa pectoralis, and they supply pretty much on the anterior and lateral side of the thoracic wall. So again, I'm just showing all the long thoracic, lateral pectoral, where they come from. I'm not going into details of the anatomy. You can just run through this. So this is again the cross section of the about third rib. You can see the innervation of the lateral pectoral, medial pectoral nerve to both pectoralis major, minor, and you can see this is our long thoracic nerve. Then there's one more nerve here somewhere, right? Okay. So this is the anatomy of the spinal nerves which supply the thoracic wall. So all this, they're like T1 to T12, all the nerves when they transmit across the mid-axillary line, they throw off one cutaneous branch either before or after mid-axillary line. So we are also interested in blocking some of these nerves while we do these PEC blocks, not just only those nerves I showed, we're also interested in these. So what is PEC now? PEC1 is blocking of lateral and medial pectoral nerve, placing the local anesthetic between the pectoralis major and minor. And most common indications are breast expanders, subpectoral prosthetic placement, or sometimes we use it for chest wall port placement. So basically we are depositing local anesthetic between these two muscles. You can use about 10 to 12 ml. You can, depending on what kind of, if you're using for post-op anesthesia, 0.25% OP is fine. PEC2 is again PEC1, which is lateral medial pectoral nerves. Then intercostal nerve from T2 to T4 and sometimes up to T6 is also blocked. And we are also interested in blocking long thoracic, which will be done with these kind of blocks. So again, here you use about 10 ml of ROP, 0.5 to 0.25%, depending on what kind of analgesia you're looking for. Are you looking for surgical or are you just looking for post-op pain management? So again, it covers the axillary coverage, it can be used for radical mastectomies, axillary lymph node dissection. We actually use for rib fractures in our hospital because ours is a trauma center. We do get a lot of fractures, so it's easy for us to just block on the place where we need to block rather than blocking the whole chest, right? And VATS, you can use it for VATS procedures, the other procedures as well. So how do we do this technique? So technique you can see, supine, all the aseptic precautions you need to take, and pretty much like how we do the infraclavicular block, you place the probe. Again, here you use in-plane technique. Because we have some vital structures underneath this chest, so we have to be careful. That's why we always want to have the continuous vision of the needle. So always use in-plane technique. And once you place the transducer, you'll have to identify pectoralis major and minor muscle. So you can put it in the pectoral groove and slide the probe down. So patient is obviously, we will not go into detail. We should have monitoring, oxygen, all those things, which I think somebody else has already mentioned. I will not go into those details. So you put the probe, you scan it, and you identify